they recommend, I think we have a slide of that, but they recommend, they stratify for high risk versus low risk. And high risk means high grade or large volume, okay? And high grade and large volume, they direct towards extirpative surgery, remove the kidney. With the caveat that if the patient has comorbidities where they're not a surgical candidate, then you can try these things. But the European guide, and there is no AUA guideline actually on this, only European guidelines. It's very interesting. But the European guidelines direct, based on those two papers in 2012, to treat modest size, less than 2 centimeter, low-grade lesions ureteroscopically first, or at least offer the patients that option. In an otherwise healthy young patient with a lesion, say 2 centimeters or larger, based on this data that Guy put together, those patients should really have their kidney taken out, because they should have longer than 20-year survival. And if half of them are going to progress in grade and stage, compared to very few, if you take their kidney out and they have another kidney as a safety, they should have their kidney out based on this data. Young patients with large volume should have their kidney out. Elderly patients who are poor candidates for nephrectomy or who would progress promptly to requiring hemodialysis, and their survival would be very short on hemodialysis. This is an option. It's an option that should be only used in very select patients. Patients who buy into this treatment have to buy into lifelong surveillance, because when they change in grade, they will promptly change in stage, and then you have to counsel them. So, for example, I saw a patient about 5 months ago. Patient had his right kidney removed for renal cell carcinoma, so he has a solitary left kidney, and the entire upper pole was full of high grade. All right. He has a history of prostate cancer. He's elderly. He's overweight. He's on a lot of medicines. His survival on dialysis would be less than a year. So what did we do for him? Well, we offered him that treatment versus endoscopically resecting it and giving him a checkpoint inhibitor. That paper in the British Journal, basically following that data, understanding that he's not going to be cured. But in his late 70s, if he gets 10 years of survival, that's wonderful, and his quality of life will be great. And so he opted for that. And his surveillance endoscopy had washings that were suggestive of high grade, but no visible tumor, and his PET scan's negative at 7 months. Fantastic. If he was on dialysis this last 7 months, he would have been miserable or dead already. So that's an example of where this is going. We're stratifying the treatment based on the genetics of the tumor. For example, if the patient has Lynch syndrome, or one of the other things you're studying right now is we're quantifying PD-L1 expression on the tumor, okay? We're trying to get people interested from a laboratory perspective on quantifying PD-L1 expression on cytology, so we don't always have to get a piece of tissue, and that's been harder to prove or work out in the lab. But as a practical matter, Guy is going through with one of his pathology colleagues, who is also a fellow, looking at percent PD-L1 expression and how those patients did with adjuvant checkpoint inhibitor and endoscopic resection, right? And he doesn't have that data yet, but I will tell you, as a practical matter, what I see in my practice is that those patients who have over 10% PD-L1 expression, they all respond. We have one patient who had, Peter had voluminous recurrence in a neobladder and in the left kidney, and was sent to a hospice 7 years ago. And we put him on Tecentriq first and then Keytruda, and he had a very high PD-L1 expression. He's been disease-free for 7 years. So this is a 50-year-old guy who was sent to a hospice 7 years ago, who we just did surveillance on, who had nothing 7 years later. Think about the gravity of that. Every time I present that slide, people say, how's Peter doing? How's Peter doing? Because he wrote a book about his experience. I said, he's 7 years post-hospice. He decided to leave the hospice and get treated. So that's pretty profound, right? That's a great story.